Good morning, everyone. It's a wonderful Wednesday morning, 5:30 in the morning. Thanks for joining us. We have an awesome presentation from Ben today that's very timely about COVID antibodies. He put together some awesome data that is super helpful. So excited to get started. Go ahead, Ben.
Awesome. Thanks, everybody. I'm going to go ahead and share my screen so you can see what we're talking through. And then here we go. So we're talking about SARS-CoV-2. You may have heard about it, antibody testing. And then a little etiology at the end called post-COVID syndrome that is not yet well defined. This first article here is the one that the majority of these first couple slides in, and then I reference a couple others, and those references are on the slides. First time I've done this presentation was developed in August, just a timestamp of 2020. It was most recently updated yesterday, 9/15 of 2020, and will probably be thoroughly out of date in about 2 months. And so there is a timestamp for this information. So just the real basics of this review. It was a meta-analysis, 54 studies included. They assessed IgA, IgG, and IgM, all common antibodies. Most of the studies were preprints, which is a complication of a lot of COVID data because they were being published rapidly without the full peer review process. And then the data also ended on April 27th of 2020, with majority being throughout the world, and then a couple of studies being in China or in the US and in Europe. So this is the data summary points. This is your standard dot plots with confidence intervals. I'm going to highlight only the ones where the full confidence interval is greater than 70% sensitivity. So if you look there, you see IgG for days 15 to 35, and then you see IgA from 22 to 35, and then you see total from 15 to 21, and total from IgG and IgM from 15 to 35 are the only ones that fall in this. And you might look here at this IgA and say, wow, that's amazing. But if you slide over, only 2 studies and 1 study were included, which does lead some question of the quality of the information. And so looking at this would say, okay, so sensitivity, where can we find a good study? You could say, well, we can look at IgG. That sensitivity is pretty good. And we can look at total antibodies. You have a pretty good window. And IgG and IgM combined, you have a really good window here with greater than 85% sensitivity confidence intervals. That's some pretty good test performance. But one thing you notice for all these sweet spots, it's 2 weeks after the diagnosis. And the study ends at 35 days, which is about 5 weeks post-diagnosis. And so there's a time course limitation for how long these studies are valid. But there's also an initial window right after the person's sick and infected where antibody studies do not help you identify diagnostic, which matches with what we know about antibodies that they're produced in response to infection. And so summary of these findings, they did include poor studies. The tests were on plasma and serum rather than on whole blood. That's significant because if you go to a doctor's office to get your antibody test done, they're taking whole capillary blood, most likely, or they're drawing whole venous blood and running the test on that. And so these tests in the lab were probably more accurate than the ones that would be done in a clinic, just because the sample of blood is more pure from the plasma serum. And then also, a lot of these tests were done on hospitalized patients, which means they had a greater severity of the illness, which means that they likely had a stronger immune response, with the exception of the very, very, very sick who had a blunted immune response. And so are these studies effective for asymptomatic patients or for mildly symptomatic patients? And that's one area where you can't apply this study to say, okay, in our asymptomatic patient, we can trust with all the similar antibody response, and the test would be likewise applicable if we're going to do it for seroprevalence. So these are all some limitations here. Based on the type of study, what it's really helpful for is showing us that there is a time course window, and that IgG and IgM are probably the ones that we want to go after. And so where the rubber meets the road, as far as potential applications, we can use it to diagnose infection, where traditional NAAT molecular testing failed to detect virus. Could use it to address the immune response. Do we get an elevated antibody response, or have we had seroconversion from IgM to IgG? And then maybe we could use this for seroprevalence or for identifying whether or not people had COVID. But again, do those only apply to hospitalized patients with severe illness? And do they only apply within that 2 to 6 week window, and would be unapplicable for your family member who thinks that they had the infection back in February? And so then you can go to some guidelines. This is a current Infectious Disease Society of America guidelines. These are verified, most up to date for them yesterday. They updated these back in August. They're periodically updating them. Of note here, there are a whole bunch. They kind of reflect the same testing for IgG 3 to 4 weeks after onset, and not trying to use these to diagnose past infection. Are two of their strong guidelines that kind of tie in with what most people want to do, which is to find out, did I have this back in February? But good caution, good education is needed for patients in this case to say, this isn't the best test for that. Here's why. You're probably going to get a negative even if you had it. Not necessarily relevant. Also of note, this limited evidence for using IgA, mostly because of the poor quality of study. It would be a wonderful test to do, especially since the IgA is so prominent in the respiratory tracts, but the studies just aren't out there to support its widespread use. So moving on to kind of these flash studies, this is a study on antibody half-life. This was in mild illness patients, which is relevant. They define that by them not receiving remdesivir. They found the half-life to be about 36 days. There's only 34 people, but that is helpful, and it shows why people might have a positive antibody response and then have a negative antibody response on a later assay. It's because their antibodies have faded. And that's okay, because we all know that immunity is not merely antibodies, but also involves B cells, T cells, and other components of the immune system. Most prominently for SARS-CoV-1 was the T cell response, not necessarily the B cell response, which is fine because the T cells can activate the B cells as well. And so the antibodies are not telling the whole immune story, and a waning of antibodies should not be overly concerning as long as we can show that there are active memory B and T cells being made that could respond to future infection. And those studies have definitely not been done yet at this point, because those are long-term chronic studies that we just haven't had COVID-19 around long enough to really verify. So then lastly, post-COVID syndrome, it's an unfolding entity. There are several categories you can think about it in. One would be persistent inflammation in the patient. Another would be long-term complications of organ damage. So I now have fibrosis in my lungs because I had significant infection, or I had microclots in my kidneys and now I have persistent kidney failure. You have iatrogenic effects, which would be muscle wasting, harms from the drugs and treatments that were done. And then you have this asymptomatic and NAAT negative patient who may have been exposed and may have some persistent symptoms, but never tested positive. And that could potentially get roped into this post-COVID syndrome, as we know a little bit more about it and have better testing to determine it. So just some of the examples of it, you have thromboembolic complications. That would be kind of like the kidney damage, complications in the heart, or anywhere else that there was a thromboembolism that caused subsequent hypoxia and organ failure. You have prolonged respiratory compromise, folks who just still can't breathe right months after. Maybe they're on a vent, maybe they have fibrosis, maybe they have continued dyspnea with exertion. Psychiatric complications, undeniably evidenced in the literature so far, evidenced daily in the outpatient practice that I see, as anybody with remote histories of anxiety, depression are complaining about, or reporting, sorry, that their symptoms are worsening. Physical deconditioning goes along with the iatrogenic effects of hospitalization. And then the persistent fatigue is one that I've heard more often than not, where folks get better, feel better, but just don't get back to their full strength. So to wrap up with some take-home points, testing window, 2 to 4 weeks after symptom onset, antibody test, IgG or combined or total, limited applications currently. They don't tell the full story. And if you have a patient with abnormal findings, it might be worth suspecting post-COVID syndrome as the cause that might unify some of the abnormal, persistent, otherwise idiopathic findings. And that's all I got for today. Thanks for joining us here on Decoding DX. Just a reminder once again, this is not information for clinical advice. This is for educational purposes only, and no doctor-patient relationship is formed.
Awesome. Thanks, Ben. That was super helpful. Very informative, very timely. Hopefully will help some of us on our clinicals and with our patients. All right. Have a great day, everyone. We'll see you tonight.
Thank you all.